so far, and any suggestions for improvement? So anybody got any burning issues, brave enough to ask the first question, please feel free to do so. I should say we will have a panel session this afternoon, a more clinical panel session with our speakers for Q&As on any of the issues you have. So you can save those sort of questions for this afternoon, I would suggest. So what about cycle to the moon? Anyone think of... Sorry, Victoria.
Well, I thought that was my point was I thought the moon cycle was a really good idea, and I would love to help you in some way in the area that we're in, so I can talk to you about that.
Thank you.
And I know Julian would love to. I'm nominating him.
Right, thank you.
I think it's a very good idea too. I saw in my local bank a few months ago people riding stationary banks, and they were raising money for charity. You know, I thought it would be a good idea if we could get, I'll try out in my region to get a few people together, get some bikes from a local health club, and we'll go around various community areas with a tin to start with. But I think we can use that. I think it's a great idea to start to raise awareness. Whether we'll get to the moon or not, I don't know, but we could make a start.
At the back. I'd like to think that that would be part of the remit of the person that we'd asked to put this together, because getting that sort of sponsorship, those connections. And the other thing is that a celebrity biker, you know, whether it's a Chris Froome or Bradley Wiggins or something, we need to ask if any of our groups have connections with someone in celebrity cycling.
I have a contact with Les Ferdinand, the footballer, and he's interested in getting involved in the prostate peddlers thing, and obviously I'm very interested in the cycling initiative, but I'm certain that he would be interested. He carries a lot of weight in the football world, obviously, and he's been on television to do with the loss of his wife's cancer and so on, so I think there's quite a lot of momentum there.
Thank you. Victoria?
The other thought I've just had was spinning classes within gyms. So lots of the people with prostate cancer are being encouraged to perhaps do some CV, cardiovascular exercises as a way of reducing their risk factors. And I know that there's some GPs, I mean very few, are referring into exercise prescription into spinning classes. That could be a great way again of getting people in a spinning class, but to do it for a period of time.
Sorry, Graham, I was just saying hello to Graham.
Yeah, so just thinking that's another way of going to gyms and perhaps using that as a forum too.
Fine, thank you. Giles, having just mentioned, I think Giles, would you just tell us about what you did in May last year?
I had a PSA of about 30 and a Gleason of 9. I'd had a test 2 years before and everything was normal, and then you know, being in the night, had another test, and that's the situation. I had radiotherapy after hormone therapy, and then 4 years later, basically I was put on palliative care, and they sort of shook my hand and said, good luck, was the actual words. I had a chance encounter with someone who turned out to be a surgeon in the village while clearing the common, which we do in the autumn when the birds aren't nesting. He was a cyclist, referred me to a surgeon at UCLH, and he said, no, we can do salvage surgery on you. So I had the Da Vinci machine robotic surgery in January of last year. When I was on palliative care, I thought I would do something exciting, and I have a sister that lives in the east, so I decided to cycle from the Channel to the south of France and raise money for prostate cancer. And having a target that was a challenge and, in a way, a metaphor for everything that we do in life, which is you set off in a destination hoping to get there, not certain of what you're going to find along the way, I found that that I became really, I realized that planning it and getting ready for it and getting fit for it really made me realize that I'd been in a very a very dark place in comparison where I was when I had this target. When I was then eligible for surgery, the one thing I didn't want to give up was my cycle ride. And so when I was first introduced to this chap, Tim Briggs, I said, am I still going to be all right for the surgery, which for my cycle ride? And anyway, it turns out that Tim Briggs is a technical term shit-hot cyclist. And he was very keen indeed. And he said, no, absolutely no problem at all. Surgery in January, and when are you going? I said, oh, end of May.
Of the day, which is what we call trials and tribulations, or I should say tribulations and trials, because the trials piece with Nick James is going to be after tea. But before that, we've got some really interesting topics for discussion, and it's about some of the issues that we're facing. And we decided to put this on the agenda this year because it's from feedback we received from members. These are some of the issues that we're all struggling with in one form or another. Very pleased to say that we've got two experts here today, and we're going to have a very enjoyable romp through, or whatever it is, for the next hour. I don't know what they're going to say. I haven't seen any presentation. I don't know whether there's going to be any naughty business on. I have no idea, but it's entirely in their hands.
It's interactive.
So, Julian and Victoria, over to you. Thank you very much.
Thank you very much. Excuse me 1 second, I have to open my presentation. Sorry, I have a fashion computer. Can you not afford a proper computer?
Oh, you want?
Yeah, I need to find out where where my stick is. You come in, sorry. I'll take my jacket off. The problem with talking to a non-medical audience is that you don't know what they know. The second thing is you don't know how they're going to be. Are they going to be receptive? Are they going to be hostile? Are they going to be friendly? Or they say, who on earth is this bloke who's come to talk to us? But we were asked to talk about incontinence and erectile dysfunction, and it was a joint presentation between me and Victoria. So, I don't know if you know who I am, but I'll tell you anyway. So, Julian Shah, I'm a urologist. I work at University College Hospital London, and I work at the Royal National Orthopaedic Hospital in Stanmore, where there is a spinal cord injuries unit, and I work for the spine injuries unit. So everybody who has a spine injury, they've got bladder dysfunction. And the most important, the interesting thing about spinal injury is, any of you are fit and healthy, you could walk down the road, bang, you could get a spinal cord injury. And when you're lying there in the bed, in the A&E, what's the first thing you're thinking about? I can't walk. Excellent. In a year's time, what are you thinking about? Bladder, bowels, and sexual dysfunction. Interesting, isn't it? So urology is absolutely critical in patients with spinal injury, just as it is in every other human being, both male and female. Bladder, bowels, and sexual dysfunction. So when things go wrong, it's a big problem. So what I'm going to do is I'm going to set the scene about anatomy, physiology, and stuff about incontinence, and then Victoria's going to tell you about how to get better without having a knife stuck in you, and then I'm going to stick a knife in you and tell you how I can make it better. And we'll try not to argue too much, Victoria and I, because I often do lectures against physiotherapists saying physio is a waste of time, but Victoria is going to demonstrate to you that it's very beneficial. Now, we should start by learning about the anatomy of the prostate. It's the prostate, not prostrate. Okay? As people often say, it's the prostrate. But if you're lying down, it can be both. But if you're standing up, it can only be the one. Now, the most important thing about the prostate is it's only there for one purpose. And what is that? Sex. Excellent. So, well, sex and nakedness, lots of dosh. But anyway, apart from the lots of dosh bit, it's there for sex. And if you don't use it, you lose it. How many orgasms should you have a month? And the answer is... Exactly. So I'll give you a number, because the thing is this. The more sex you have, the better it is. It reduces the risk of prostate cancer. So, 21 orgasms a month. You're nodding in a very... I've never seen a woman look so happy. Well, you can have a rest, yeah, exactly, once a week. So,
if you do it all in one day, does that count?
You must be a lion, sir. A lion can have 200 orgasms in a day.
Moving on.
Anyway, it reduces the risk of prostate cancer by 15%. But you've got to have done that all your life, I'm sorry. So it's a bit late to start, but there's never too late to start. Now, the important thing about it, just to give you the anatomy, the bladder lies here, and the prostate lies around the urethra. Okay, so the prostate connects the bladder with the urethra. Now, men have two sphincter control mechanisms. The first is at the bladder neck, called the internal sphincter, and the second is the external striated sphincter. So those of you that faced radical prostatectomy can imagine that if we cut out your prostate, we are ridding you of your bladder neck and also part of your sphincter mechanism. And this little structure here, which lies inside the prostate, which is here, which is called the verumontanum, was put there by God so urologists could do prostate surgery. Okay? Because if you stay above this level when you do a prostate operation, you will not make your patient wet. Once you stray below there, then there is a risk of causing incontinence. So it's a very important teaching aspect of prostatic surgery. The prostate's an organ of sexual reproduction. It's a bit like your salivary glands. Your salivary glands work, don't they? Every day they're producing fluid. And you're using them because you're eating. So you imagine your poor old prostate, it's making fluid. It's got to come out of there, it's not supposed to stay in there. So ejaculation is very important. And the ejaculate contains fluid which is very relevant to sperm function and for allowing the sperm to penetrate into the uterus to make babies. The things you have to remember about the bladder are two essential components. And this has relevance to everything in terms of continence. The bladder is a storage organ. How much does your bladder hold? You're looking perplexed.
About a pint and a half.
A pint and a half, Jesus. Okay. What about your bladder, man?
300 to 600 mils.
Have you measured
Nice
it?
baby.
Okay.
300 to 600 mils.
You're copying that. 500 mils. Okay, very good. So the answer is 500 mils. Okay, your bladder may be able to hold a bit more if you're a bit of a drinker. Okay, or if you've had a few pints.
Don't judge me.
if you've been sitting drinking all through the lecture and you haven't been able to pop out. But when the bladder stores urine and you were to measure the pressure inside it, the pressure would be low. So the first rule of the bladder is low pressure storage. When you go and have a pee, you stand there or you sit there and you pee, when your bladder has finished peeing, it should be empty. Zero residual urine. That's why we say, I'm going to empty my bladder. You wouldn't say that if it was half full, would you? All right? So if there's anything left behind, that's called residual urine. So if there's a change in the balance between storage and emptying, it's dysfunction. Now incontinence is very, very common. There are millions and millions of men around the world incontinent of urine, many of whom are never discovered, or they don't come forward and they put up with it. And that's a shame, isn't it? There's lots of causes of dysfunction in the urinary tract. Of course, as you age, two things happen. One is, we men, our prostates enlarge, and it starts to squeeze the tube through which you pee, and you get bladder outflow obstruction. So you find, how many of you have to wait before you start to pee? I was in the toilet earlier on. Somebody was taking a very long time to pee. Obviously got bladder outflow obstruction. I've got bladder outflow obstruction, I know that. It takes me a bit longer. But it doesn't matter if you don't have any symptoms by and large. But as we age, it takes longer to get going. The flow is a bit slower. It's more over your boots than in the trough. Okay? And if you have a tendency, that's why Bob, where's Bob over? Yeah, Bobo took a long time to go to the toilet in the service station. So when you go to the service station, you're standing there in a line, aren't you, with all those urinals, with those terrible posters saying, have you got erectile dysfunction? And the bloke next to you has always got a white t-shirt, a bald head and a tattoo, isn't he? You try and have a pee, you can never get going. It's terrible. So that's all about bladder obstruction. The other thing that happens is, as you get older, your bladder can become unstable. So in other words, when it fills, it spasms. And obstruction causes instability. So you get this association between aging and bladder outflow obstruction. Of course, other things that happen as you get older, which cause symptoms, is constipation, because your bowel function can change, and weakening the pelvic floor. Again, Victoria will talk about that. And certainly, general fitness will affect avoiding dysfunction, it can do, and especially in ladies, if you're very overweight, it can lead to incontinence of urine. So, when you have bladder outflow obstruction, you will get a combination of symptoms. And these Venn diagrams where you get overlapping symptoms, avoiding symptoms, frequency, urgency, wetting, and that sort of thing, they're very common in men. Just a brief word about this. Anybody feel these symptoms? Yes? Who's got those symptoms? Yes? I bet you. All right, hands up who's got an overactive bladder. Hands up. Well, there's about 70% of you are lying. So, let's be honest about it. If you had, remember I said storage and empty. The symptoms that bother you most are the storage. It doesn't matter if you take a minute to pee, okay, as long as you're not in the service station. Because as they say, 1 shake's allowed, 2 shakes is masturbation. But when you have to rush to the toilet or you may wet yourself, that's a symptom that's significantly bothersome. And you can see that the symptoms that cause bother are getting up at night. Who gets up at night? Yeah, that's a bit more honest. When I want to go, I've got to go. If I don't get there in time, I may leak urine. Going frequently during the day, sorry? Yes, Karen?
Do these figures, do they change between men who have got a prostate and men who've had their prostate removed?
When your prostate's been removed, your symptoms improve. So if you take 100 men with bladder outflow obstruction, 67% will have unstable bladders. When you operate upon the 100 men, of the 67% with unstable bladders, 75% will get better. Okay? So surgery will relieve those symptoms. That's why when we operate upon you, we make you better, which is good. So surgery does have a benefit. Symptoms of overactive bladder, they are prevalent throughout society, both in men and in women, and they increase as you get older. And you can see, by the time you get to 70, a quarter of men and women will have unstable bladders. Okay? Bladders that spasm when they fill and make you want to pee. But we can make them better, and I think this is the most important thing, that patients don't realise they're out there suffering, and yet we can help you a lot. And so I think by giving you very simple treatment, help to make your symptoms better. Victoria will talk about it more in detail. And even surgery can be beneficial. Botox, very good to treat overactive bladders when they're very troublesome and you're wet, and it's not being made better with pills and other things. So I have a motto, making the wet dry. There's no reason why anybody should be wet. We can make you dry. Of course, many of you come here to hear, well, what happens when I've had my prostate cancer? I've had a radical P, radical prostatectomy, whether it's open, lap, or by robot. You know, everybody thinks this robot thing's a big deal. Look, robot is just laparoscopic surgery with a man playing a computer game inside your belly. All right? So, which is that's all it is. You know, he's enjoying it, sitting down, playing games. I'm an expert in open surgery, but the results are the same whatever you do. It's just that you go home quicker when you've had it done with a robot. In terms of other treatments, HIFU, high-intensity focused ultrasound, TURP, brachytherapy, radiotherapy, all of those things can cause incontinence. But if you look at the figures, incontinence after laparoscopic surgery, 12%. So it's quite a high incidence of incontinence. And I think if you're going to warn patients about what are the potential risks of my having this surgery done, the answer is the things that bother you most are incontinence and sexual dysfunction. And that figure, which is 39% for sexual dysfunction, is probably an underestimate. It depends upon the stage of your disease. and how difficult the prostate was to take out and whether the nerves were preserved. So when you have prostate cancer treatment, then you can get any number of symptoms which can be exacerbated by that treatment. An overactive bladder, urinary incontinence, fecal incontinence if you've had radiotherapy, fecal urgency, erectile dysfunction, pain, and of course all of this is a cause of great distress. If you've had a radical prostatectomy and you're incontinent when the catheter comes out, it's almost invariably due to the fact that your sphincter's weak. And when you think about it, when I've cut out the whole of your prostate, so taking your bladder neck and a third of your sphincter, is that surprising? You lost the support from your prostate, Victoria will show you later. And so it's not surprising that you become incontinent of urine, but usually that will improve with time. And those of us who are surgeons, we won't operate on anybody for a year, because the majority of patients get better within a year, helped usually by a physiotherapist. But if the patient is leaking on the floor, that's usually due to sphincter weakness. But there can be other components which are urgency frequency, the key in the door syndrome. Anybody felt that? Running water, all those things, they make your bladder want to go, don't they? And that's an unstable bladder situation. If those of you who've got no other incontinence problems, but when you've had a pee and you put your willy away and you leak a few drops, that is a post-void dribble, post-nutrition dribbling. Who gets that? Yeah, you're all lying. You're wearing white trousers, Sasha. You know, if you go to a swimming pool, and you know how you put your trunks on and you have a pee before you go in the pool? If you look at the guys with towels in front of their trunks, they've got post-McDribble. Or it's that lovely sunny day and you're wearing a pair of white trousers, a very bad idea. So remember, these problems can occur. I'm sure some of you have experienced these problems, and they're a cause of great distress. Of course, the first thing you do is you go down to the shop and buy some pads. You know, the sort of thing they advertise on the TV for ladies. Very embarrassing. And you do see men with pads like that, men with big nappies, and it's very, very distressing. Men do not leak. True? Women leak. It's a leaky old thing being a woman. Especially if you had a couple of babies. Okay, that's true. Put a bunch of women over 40 on a trampoline. It's like going for a swim. Men don't have that experience. So what happens to us, it's a disaster. And of course the size of the pad is very important, because of course pads can be very absorbent, but nevertheless it's not nice carrying a weight around in your pants like that. So, but of course it's very much affected by the individual, because some people say, oh, I don't mind, I'll wear nappies, it's fine, I'm happy with it. And some people aren't. It's all about personality. A few dropped to some can be a disaster, and 100 mils to another may not be. So I think when we assess the patient, obviously we have to assess how bad is it affecting you, is it to the point at which you want to have something done. So continence after radical prostatectomy should be, I do not leak. So if you're leaking, you're wet, whatever the amount is. But of course, what you do is about how you feel, how the patient feels, and you don't intervene unless it's necessary. I'm going to hand over to Victoria. Victoria is a specialist physiotherapist in the pelvic floor. She works in Bedford. She's extremely good at what she does. We have endless discussions about whether her treatment is effective. But she's going to yes, but she's got no technical skills. So,
following on from June is always incredibly difficult. So I'm going to start with my first question. Who has actually done any pelvic floor exercises this morning?
Oh, this morning, yes.
Yes, that's quite honest actually. Okay, so I'm going to ask one quick question. Why? Why haven't any of you done them?
Didn't have time.
Didn't have time, that's a female answer.
Just forget about it.
Forget about it? Yeah. Who's not been told about it?
Yeah. Oh, yeah.
No access to that treatment? Yeah. Okay, so we'll come back to that. So what is the pelvic floor? Does anybody else want to just give some answers to what it is? I like interaction. I'm a physio, we like interaction.
Bottom of the pelvis?
Thank you, bottom of the pelvis. What's it made of?
Muscle.
Muscle and fascia, so it's muscle and soft tissue. Okay, and it's really important, and I'm afraid I do think the landmarks are important. So if I had a willy, okay, so,
Thank God you didn't.
pubic bone here, tailbone here, so there's the muscles between our legs. They go from front to back, so it goes from pubic bone to tailbone, and it goes from side to side, okay, so it's really important. And if we just look at this, the pelvic floor is made up of 2 layers, so there's what we call the superficial layer. I'm going to get June to help me probably on this, where there's bulbocavinosis and the ischiocavinosis, so they are mainly for sexual function, although we might argue on that one. And then we've got our deep pelvic floor muscles, which are really important for our continence. But quickly, what is the other roles? What are the other roles of the pelvic floor? What does it do?
Keep everything in.
Thank you. So it gives support to our pelvic viscera or our pelvic organs. So in the chat, we're talking about our bladder, prostate, and our rectum. I have to look, Mr. on that one. And in women, obviously, we are also including our uterus. Okay, what else does it do? It's what a lot of you will be complaining about. Very important for continence, we've just been talking about, haven't we? So it's a muscle that doesn't work a joint, does it? So its action, when it tightens, is to compress and be sphincteric. So, if you think about it, it's very important because through the pelvic floor passes the outlet from the bladder and the outlet from the bowel. So we're talking about our urethra or our water pipe or our rectum and our anorectal angle and our anus, okay? It supports the pelvic organs, it's very important for sexual function, and from a physio point of view, we talk about it as part of our core muscles. So if we're talking about our core, we're talking about our trunk. We know that if the muscles in our core are working synergistic, i.e. working well together, we're going to reduce some of the problems in our musculoskeletal system as possibly well improve our continence. But I'll come on to that. Okay, so I've said there's 2 openings. So Julian's done quite a lot of the anatomy, well, done the anatomy with you. So we've got our water pipe, we've got our 2 sphincters, we've got our anal sphincter. But what is really important to be aware of is that the pelvic floor muscles give fibres off to these openings. So if you've got a good, strong pelvic floor, it's going to reinforce the closure pressure from these organs that hold bodily matter. So fluid or stool, okay? Or wind, that's a big one. Okay, so what can weaken them? We've already talked, Julian's already covered most of that, but obviously any prostatic surgery could cause problems later. We know about radiotherapy, the effect that it's much more targeted now, but actually it has a huge effect on the tissue. General fitness, I'm a huge believer that fitness is really important, because if we meet a chap who's got to have prostatic surgery, and I think Charles has already covered this earlier, who's quite deconditioned before his surgery, so the tone in his pelvic floor is already poor, he may already be getting a bit of some symptoms because of his general state before and his poor pelvic floor function. Weight is a big issue, but we'll come on to that. But if you are carrying a lot of weight, where's it going to be just sitting with gravity assisted, but onto your pelvic floor? So potentially that can be having a detrimental effect on what the function of it should be. Constipation is my big bugbear with all my patients. Why is constipation such a problem?
Pressure.
It is. It's a downward continual pressure repeatedly onto the structures that should be supporting our pelvic organs. And neurologically, that can be due to injury or some actual disease process, and direct injury to the perineum and the pelvic floor can affect its function. Okay, Julian popped this in the presentation, but I think if you just look at where the prostate is and what happens afterwards, you can see how it's very obvious that there can very easily be damage to your continence mechanisms. Okay, again, this is a picture of all people who've had a radical prostatectomy, and the point that's got to be made is that the bladder neck, so that is obviously the outlet from the bladder, is now below the level of the pelvic floor. So can you see how your continence is really challenged? Okay. One thing I looked up, if you've had radiotherapy and there's been a lot of scar tissue, that also can affect your actual closure pressure of your anal sphincter, because your anal sphincter is very close, okay, to where they will actually sometimes target some of the radiotherapy. Okay, so what's the impact of incontinence on life? Well, I think this is something that we often forget. When people have got a diagnosis of cancer, what's the thing you just want? Is to get rid of the cancer, don't you? What do we want as clinicians? But we want to cure you, or at least get you, hopefully to cure you. And then it's the year later, as June's already pointed out, where actually I'm living, I've got the survivorship issues now, because my quality of life is affected by the treatment I've had. So we do know that for a lot of people, the consequences of their treatment leaves them actually
I would say that depression is a very high comorbidity of any cancer treatment, but there is a lot that can be done if we can get the right access to the treatment. And I think it's also down to us as clinicians giving people the voice and telling them where they can go to get the help. And I think that's something we forget. Okay, so where's our role? Well, I'm going to grandiose it hugely now, try. So we are very much part of the MDT team, so we will sit in meetings where patients are discussed. We'll put through and sometimes we'll suggest where we can help in terms of conservative treatment. I really believe in integrated working, so I work hugely alongside of the specialist continence nurses because I've learned so much from them. I believe it's a quid pro quo. I also think one of our very important roles is listening to what the patient wants, not what we think they should want. But some of our patients don't want any further surgery. They're happy with containment products, but what they do want is a good containment product. So we need to know where we can access that for them. I had one patient who had very bad fecal incontinence, and he absolutely loved going into London to go to the opera. But what he got was terrible fecal urgency. Once we could get him what's called the radar, it's the key that accesses you to all disabled laboratories in England. Some of you will probably know about this. That changed his life. So he had the confidence, because one thing we knew was his urgency was made worse by the consistency of his stool. So once we started giving him something that gave his stool more consistency, like loperamide, and we taught him what we called urge suppressant techniques and said, you've got your key, you can lose any loo, he didn't have as many symptoms. So that was again about us listening to the patient and working with him on lifestyle management. Okay, and once he had the confidence to actually volunteer, he had the problem. Okay, so we do try to, I think when I put it on the point of support, I think sometimes the handmaidens to our consultants do forget how important we actually are as a point for our patients, because sometimes we can go back to the consultant and say, he's really not keen to do that. Have you thought about suggesting something? Well, do you need to go and talk to him again? Okay, so that's about trying to make you involved in the treatment process that you're undertaking. Okay, so the symptoms, Julian's actually really covered these already. The daytime frequency. Now, frequency for me is a big issue because I'll talk to my patient. How many times in a day should you have a pee? Approximately.
4.
4? Whoa, somebody's got a problem. 10, okay. 7. Well, I say 7. You're all just saying 7, including one at night, okay? Now, frequency can be an acquired behaviour because you're frightened of having a problem and not getting for loo in time. So what you do is, every laboratory in your town, you know exactly where. You know, the bus station is pretty ghastly, but Devlin's is okay. And John Lewis is really nice, they've got nice handwork. That's what my patients all tell me. So frequency is something that we, in my assessment, and I'll come on to that, will do what we call a frequency volume chart with a patient. We'll look at what the reality is of what they're doing. Is that actually being triggered and they need to go to the loo because they functionally really need to go, or because they're going just in case? So we may need to modify what we're doing and then instigate some battery training with them, but we'll come on to that. Is it normal to get up at night? My argument is that over 65 once at night is, but I think that if you're getting up a lot more, that perhaps needs to be again looked at your frequency volume chart, because some chaps are so frightened about drinking in the day because they've had the experience of incompetence that they fluid load at night and they're up all night. Or it may be, a point that we often will see is that some people may have other illnesses or comorbidities going on, and they may have a few cardiac problems, so they've got a lot of peripheral swelling of their hands and their ankles by the end of the day. Lie down, it all comes back to their central cord, and they're constantly up and down needing to pee. So they may be the sort of patient we need to look at when they're taking the diuretic, and do we need to change the time they take it to reduce their getting up at night. That doesn't always work, actually, but anyway, it's worth a try. Julian's talked about urge incontinence, post-micturition dribble. For me, that's one that actually is pretty easy to manage, because what you need to be teaching the patient, when you've had a good pee, stand there and do a very strong pelvic floor contraction, because what you're then using is the bulbar cavernosus muscle to actually try to milk out any of the urine that is caught in the bulbar urethra. I sometimes will teach a patient again, if you can hear me, to lift up the testicles and put a bit of pressure underneath, because that might just help to milk out any of the urine. I mean, shaking and whatever Julian said, but be a bit careful while you're doing it, but you know. I will have to say, as a physio, I treat double incontinence, and I think my patients with bowel incontinence, I take my hat off to any patient who's managing their urinary symptoms well, but having bowel problems is an enormous issue for patients. And I think it's underestimated, because it's who wants to talk about poo? I do all day, by the way. People don't want to talk about poo, do they? And they certainly don't want to tell a nice, pretty young nurse who might be seeing them that actually I'm having a problem holding my bowels when I go to the rugby. But it's something that is very treatable, but often has to be instigated by having a bowel regime that you might implement in the morning that gives you the freedom of being able to carry on during the day. And there are other things like peristine anal irrigation that if we teach a patient to use that, which may sound a bit, oh my God, where's she going on that one? But if you can get them to empty their bowels early in the day, they have the security of knowing that when they go out later, they may actually not have another problem. Some of them will teach them to use anal plugs, and it can be also with the help of medication. Erectile dysfunction is something that I have some experience with. Sorry, I can actually not do do you want to take over, Julie? No, but pelvic floor exercise, actually, there are no physio evidence-based trials where they've actually just chosen physiotherapy as a treatment for erectile dysfunction. But there's lots of papers anecdotally where they have shown it really does help. So we know, we'll come on with strong pelvic floor contractions when you have got some tumescence if you continue it. And we try to be systematic in what we're doing, but as you can tell I've got verbal diarrhea, so we often go a bit off-piste with my patients. But anyway, we try to stick to it. And we'll do a full assessment of all their past medical history, their presenting symptoms. One thing that I'll come back to, and I'm sure that any of my allied healthcare professionals in here will know, we try to goal set to what the patient wants. Okay, that's so important. I will do frequency, volume, charts. You all know what those are, but we're looking at your intake, your output, any issues with urgency, was it mild, moderate or severe, and what's your trigger for leakage? Because sometimes it's not that obvious, but it can help. And it really helps us to see, this patient says, you know, oh, I drink plenty. They bring a chart back, they've got two months of black coffee and 4 pints of bitter, and they wonder why they're wet. So I'm sorry, I'm a bit naughty, but they're taking a lot of black irritants. Okay, we might, if they haven't been done, or during my process of treatment, thinking this patient is peeing, but then within a few minutes they're leaking again, we might do some pre and post void scans to see if there is an element of going into a bit of retention, a residual volume that then with movement is being pushed out, and then we go refer back to the urologist. And the bowel diary is similar to a frequency volume chart where we're recording what's happening for the patient on a daily basis and how we can intervene. This is just a very short example of what one frequency volume chart could look like. Okay, now the objective assessment from a physio point of view is like I would do for any joint. I will be looking at the muscles that may be surrounding a joint to see what we can, well obviously looking at the bony structures and everything, but looking at the muscles and what we can be doing to improve range of movement. So in a urological or urogyne assessment, we are also looking at how the muscles that indirectly and directly help continence, how they are working. But we'd also be looking neurologically at their neurological system to see if there's any neuromuscular deficit that might be affecting them being able to work the pelvic floor. We're certainly looking at the skin to see how the skin is. Is there evidence that there is quite severe incontinence? Because some people might very underestimate when they talk to you and examine you, think, crikey, they must be in so much discomfort. They're red raw. So there's some sort of just topical things and ointments we can give them that can actually help the skin status, because obviously that would mean, if it's in a bad way, that predisposes you towards infection. What I will then do is do an assessment of the pelvic floor muscle function and strength, and that does involve a digital examination. So at this point we do have to make sure the patient's sitting down, and we do counsel them well about why we're doing this. Because if I say as a physio I'm going to do a digital examination, a rectal examination on you to assess muscle power, the door opens dramatically. But what we should explain that is the only way that we can really check that a gentleman, or one of the ways, not the only way, is doing a correct pelvic floor contraction is by being able to feel the muscle. Because to re-educate the pelvic floor, there's no point me just talking to a patient saying don't forget to pull up or trying to stop this doing. The patient goes yes, yes, and more than they what the hell is she talking about, and is doing the completely wrong thing. Because chaps, when they do a pelvic floor contraction, love to pull their tummies in and not to recruit the pelvic floor. And then you're increasing the pressure in your tummy, which often ends up pushing urine out. Okay, but we'll come on to that. When I do my assessment of the pelvic floor, we do use what's called a validated assessment tool, and it was based on the Oxford Muscle Assessment Scale, which is where you look at a muscle from 0 to 5. With men it's from 0 to 6, because obviously you're stronger than all of us, and that's just the way we assess what the baseline power is in your muscle. Okay, so that was just here. And what we feel very strongly as physios is that every contraction should count. So if I was looking at the quads in the past, if you look at any research about re-education of the quad muscle, We know that when somebody does a maximal contraction, their first maximal contraction will be them feeling the pattern of the movement. That's them just doing the exercise and knowing what they should do. It's your second and third maximal contraction that is going to be really working on hypertrophy of the muscle. So that's what you need to be working on. So does that make sense? So when I'm giving a regime to a patient, I want to make sure that I'm giving a regime that's specific to the muscle function, but is actually going to increase the strength and the speed with which they can recruit the muscle. Because the pelvic floor is one of those, what I consider awesome muscles, forgive me using the youngsters' word, that muscle actually works the whole time. It's got to have a baseline tone in it, because if you were all sitting here, if you didn't have some tone in your pelvic floor, we'd all be wet. Okay, so there's some baseline tone, but then, as we get to the point of our filling capacity, and we may be getting that first desire to void, or thinking, crikey, I've got wind and I need to stop it, because it's really not appropriate to let rip here. May never learn that, do they? But anyway, so what you're then trying to do, you've got to be able to use that muscle quickly to get the muscle working, okay? So we'll go on to that. So, what we're trying to do is to counter, the pelvic floor strength training is to try to counter the increases in intra-abdominal pressure when you're doing activities. Because if you think about it logically, if you increase the pressure in your tummy, where's it pressing? It's going to be pressing on your bladder and your bowels. So if your closure mechanisms are poor, it could be during bending, walking, playing golf that you have your leakage or you lose wind or very unfortunately will lose stool. So we're trying to counter that. So we're trying to have a responsive muscle structure that works against forces that press on it. Okay? We're trying to ensure, also, like I said, after you've had a wee or when you've opened your bowels, we might say after you've done that, try to do a strong sustained contraction so you can ensure that you actually have finished what you've just been trying to do, okay? So that's a strategy. And then we'll use a strong pelvic floor contraction as what we call one of our urge suppression techniques, because we know for a fact, if I just go to the next slide, that what causes bladder and bowel urgency, so urgency is a symptom that tells you that you might need to want to go to spend a penny, and that's to do with the contraction of your detrusor muscle, which is the bladder muscle. And it's the same with the rectum. It's constantly sampling what's in there, and will be sending us cues to become cognitive that tell us that we either need to go to the lavatory to pass urine or to open our bowels. But obviously, sometimes that urgency can be so strong that it actually overwhelms our continence mechanisms and we can have leakage. And then, what happens to the person? They get extraordinarily anxious, they start to tighten up their tummy, they're pulling everything up, their breathing becomes more rapid, and guess what? The muscle's completely fatigued and the whole world falls out of view. So one of the strategies we might do with the patient is urge suppressant, both for the bladder and bowel. This isn't quite the context where we could talk you through, but that is something you've got in your leaflet, and we can go through individually if you want me to. So these are the ways we do. We do say to a patient, which always sounds so, keep calm. If you tell somebody who's just frightened of leaking, you say keep calm, they absolutely want to punch you on the nose. But what you have to try to explain to a person is within the comfort of your home, in terms of bladder retraining or urge suppressants for bowel movement, the last thing you need is to ratchet up your cortisol levels and your stress levels. Because what happens in fight or flight? You often want to pee or poo, don't you? If you get more and more anxious, you're going to make it worse. But it's something that what we have shown, and even all the seminal work, in particular bladder retraining, it's quite intense therapy between the therapist and the patient to keep them compliant, trying to use this to improve their symptoms. Okay, so nice that we covered these. We really want to try, and Julian's covered quite a lot of them, making sure people are drinking appropriately. Do all of you try and get your 2 litres of urine in every day?
Not yours.
That would be interesting. Please forget that. 2 litres of fluid in a day. What should you not be drinking too much of?
Oh, coffee.
Well, I'm not giving up, but moving on that. But tea and coffee, because why? Because we know that caffeine is a muscle stimulant, and if you think about it, the bladder is a muscle with a waterproof lining. If you keep drinking drinks that stimulate the muscle to have an action potential, the action potential is where the muscle contracts, that's your sensation of wanting to pee, it's going to be a driver to make you want to pee more. So sometimes if we just reduce somebody's caffeine intake, their frequency and urgency gets much better. Not always, can I say, because if you've had surgery or you've had radiotherapy, the whole of your urological system has been given a damn good kick. So it isn't just an eye stuff, but it could be a component that you could improve your symptoms. Okay, so we try very much to make sure that somebody is avoiding constipation, because we've already covered that. If you're constantly straining to do a poo, you're stretching all the soft tissue structures in your pelvic floor, so you're going to compromise its function. Okay, what are some of the basic things you need to do to try to improve constipation? Seems to be human beings are very good at not dealing with it.
Plenty of fruit. Fibre.
Fruit and fibre.
Fluids.
It's really your fluids. It's your fluids. And I'm sorry, but go back to Charles, it's exercise. You need to move. If you don't move, you don't stimulate the bowel, you don't get the desire to go. And I'm going to be honest with you, people are on diets. I always say to a woman, she says, oh, why don't you go until the evening? I said, well, you're never going to lose weight. You've got to eat little and often to keep stimulating your metabolic activity and to stimulate, I always get this the wrong way around, the gastric colic reflex. So you can stimulate your peristalsis to want to go to the loo. It's not the right place here to do it, but also the way you sit on the lavatory and how you use your abdominal muscles is vitally important to stop stretching the pelvic floor. There just isn't time to go through all that today, but we normally do. So, quickly before I go any further, would somebody tell me how you do a pelvic floor exercise? How would you tell one of your mates in the pub who said, God, you know, John, every time I sort of move, I'm suddenly peeing. How would you say to do a pelvic floor contraction?
Use the muscles that you try to stop yourself passing urine mid-flow.
Yeah, okay, so stopping your urine mid-flow.
Stop passing wind.
Yeah, men always get that. It's funny, isn't it? So I always say to a chap, sit on a hard seat. Actually, let's all have a go, because I think Roger thought that's good. So if we all sit on a hard seat, find your sitting bones, so sit on them, okay? And what I want you to try to do is to relax your buttocks, and I want you to try to relax your tummy, all right? And I'm going to ask you to do something quite bizarre, but I want you to try and think about your undercarriage. Lovely. Okay, so you're bursting to spend a penny, so you're going to try to tighten at the front, and you've got wind, and you're going to tighten around your back passage, so you're trying to squeeze, draw up and in.
How long for?
How long for did you say? Okay, the other thing is you do need to breathe. Really quite important. So from a physio, when we teach you, we do it a little bit Pilates based, so we'll get you to be focusing on your breathing. We'll say take a gentle breath in. As you breathe out, tighten around your back passage and come forward, and with chaps it's nuts to guts or testicles to spectacles. So what you're trying to do is gently try to lift your testicles up or draw your willy or your penis, whichever word you want to use, forgive me if I said the wrong thing to anyone, towards you, okay? Can you all do it? Everybody can do it. There's a few people, I love that face. You always know somebody's doing it. It's a very good look. Okay, but being really serious, I'm moving on rapidly. From a point of view of trying to get this muscle to work, you do need to do both endurance training and fast reaction. So there is no point just flicking it a few times and thinking, I'm doing my pelvic floor and it's going to work. I will meet many patients say to me, Victoria, I've done my pelvic, they just don't work. And I say, Kevin, so what are you doing? Well, I flick it every time I sort of think about it. You wouldn't go and do a marathon by going for a walk once a week, would you? Any muscle that needs to be built in strength needs to be regularly said hello to. So I would say to patients, you've got to start having a relationship below your belly button, not the one you used to have. Okay, all right, so what you're going to do is either, and I do 3 different ways I get the patients to start lying and sitting, and they get them to try to do 10 of their long hold, all right? So what I say is, I'm not going to tell you to hold it for 10 seconds, because if you can't hold it for 10 seconds, you're going to be demoralised. You have to find your own starting block. So if your starting block is a 5-second contraction, really pulling from back to front, you'll get a tiny bit of tightening in your lower tummy, that's okay. But if all your tummy's pulling in, stop, start again, okay? It's really important that you have the rest period afterwards. Why? Thank you. Sorry?
So the muscle relaxes.
Yeah, but you would be amazed, because we talk a lot about muscle strength training and physios have had to acknowledge this. We were going around saying you've got to have a strong pelvic floor. So many people were working so hard to strengthen the pelvic floor, we're now treating them for chronic pelvic pain because they can't relax it anymore. So you wouldn't, if I want to wear my bikini, which those days are gone, I would have done my tummy exercises, but I wouldn't walk around the whole day with my tummy pulled in because I get constipation for a start. But do you see what I'm saying? A muscle needs to be exercised and then relaxed. So it's really important. So you try to do up to 10 of your long holds, followed by 10 quick ones in sitting, lying and standing 3 times a day. Now, people say, what, 10 times each time? I say, no, 3 times in sitting, 3 in standing, okay, and 3 in lying, but 3 times a day. And really try to focus on maximum contraction. Now, I then teach patients that when they're going from sitting to standing, that they try to remember to brace the pelvic floor as they do it. So they start to use it functionally. It's called the knack. So if I was going to get Julian to go from sitting to standing, I would try to make sure that he gets up where he's not bending over and furniture walking, but he sits right up. I'm Julian wouldn't. And also that he's actually braced his pelvic floor whilst he does it to counteract the effect of potential increases pushing onto the organs and causing leakage. So that's, again, we try to, if I've got golfers, I'm afraid I get them with probes in places you don't want me to talk about here, and I get them pretending to swing a golf club to make sure they've still got their pelvic floor muscle recruited whilst they're doing it. So we do try to address it functionally. So here I've also said that it's quite important sometimes, if you feel you can't do it, is to self-examine. So if you have the confidence to examine yourself, lifting up your testicles and putting pressure behind your testicles but in front of your back passage or anus, when you do a contraction you should feel that muscle drawing up and inside you and pulling away from your fingers, okay? And then you know that you've done the right thing, all right? Sometimes, and a few of my colleagues have told patients to stand in front of a mirror. I'm afraid in the privacy of your own home, fine, I don't do that in clinic. But if you do it, I know lots of them do, but I'm afraid I don't. What you're trying to get the patient to do is to see, can you see your willy pulling in towards your body and your testicles drawing up? But that's something you can do at home. Okay, I do say to all my patients, be patient. A muscle, any skeletal muscle, takes between 6 weeks to 6 months to strengthen. So if you go back to your physio after 2 weeks and say, well, it doesn't work, I just say, well, go home and try harder. No, I'm very bossy. I am actually. But you cannot expect a muscle that you may have had no relationship with before to suddenly get you back your continence or your erectile function within the terms of a few weeks. I think we're nearly there, Junior. So that's what we try to do is sub-maximize said, and as you're in terms of walking, so you are using the muscles whilst you're walking, you're trying to get them to work a little bit, so there's some tonic activity going on. We do then, in clinic, I would do a lot of things like biofeedback, where actually sometimes for the patients who are game, and we know that it's safe to do it, we might use probes, actually either surface electrodes or gently put inside the back passage. Most men, when I say I'm going to do that, say I've been through so much, just get on with it. And then we link it up to a computer screen and we do biofeedback. So we set them challenges on the screen that they've got to meet by using their pelvic floor. Many of my colleagues use real-time ultrasound where they've got, I just can't because it's very expensive, but, and they would buy it for me, but that's another way of actually giving you a visual auditory cue for you to be able to see the muscle and try to work. Men love it because they're so competitive. And I'm pretty sure, so I think we're brilliant, Julian does too, and now I'm going to pass over to him.
I found that slide.
I had it anyway.
I can guarantee that Victoria can give you a 2-hour lecture in 30 minutes. 10,000 words spoken in the sound of 5,000 words. Of course, when the physios fail, then it becomes a bit of a problem, doesn't it? And you don't fix everybody, thank God for that. And so the patients will come to us, the surgeons, and they say, come on, I've done all my exercises, and it's worked, but it's not worked enough, and I'm still wet, and I'm still wearing a nappy, and I hate it, and you might be 50, 60, 70, or 80, you don't want to be wet. And the most important thing is, can we, urologists, fix you? And the answer is, yes, we can. We can pretty well fix anybody who's incontinent. So, in a male with incontinence, of course, as Victoria says, you take a history, and you get a questionnaire filled in, and then we will do, almost invariably, urodynamic studies. Urodynamic studies is a pressure test. I'll explain it in a second. One thing we've got to exclude is a thing called overflow incontinence. That occurs in patients whose bladders are overfull, a bit like that sink overflowing. So the bladder is very full. You may find that you're dripping off the top of your residual urine, and it's simple enough to diagnose. Put a hand on the tummy, the bladder is full, as you can see on this picture here, a bit like if you start to develop bedwetting. When you're in an older age group, you need to exclude chronic retention as a commonest cause, because that occurs, obviously, without you having had any surgical intervention. So if a patient comes for the first time and they're wet, is it overflow incontinence? Is it bladder overactivity? Those are the two commonest causes, and we can fix those things. However, if you go and see a surgeon, a urologist who's going to treat you for post-prostatectomy incontinence, then certainly in my centre, we will do urodynamics. Urodynamics is a pressure test. What is it telling us? It's telling us about function. You don't know what the bladder is doing until you test it with this. Chris Booth and I, we've known each other since 1980.
78 to 80.
Yeah. Chris Booth was working at the Middlesex Hospital in the aerodynamic unit, and I took the job that he left when I came down from Norwich in 1980. And so I've been doing aerodynamics for 40 years, and this test is the gold standard understanding of bladder dysfunction. Whatever you have done surgically, it's better to have aerodynamics before it's done. And what you do is you fill the bladder whilst measuring pressure during filling, and then you measure the pressure during voiding, and that tells you about function. So if you've had a radical prostatectomy, you're wet, we need to know about function. Is it the bladder's not storing well, or is it the sphincter that's leaking, or is the patient obstructed? If you have incontinence, can you use other things than the pads I showed you earlier on? Well, you could put a penile clamp on your willy, okay? They're not bad things, as long as you don't put them on too tight, otherwise your willy will drop off. But they can be useful in the man who's awaiting a surgical solution, who doesn't want to wear a condom. Catheters, we will very rarely use. I don't like catheters. There was a gentleman earlier talked about having a catheter. Catheters, by and large, are bad. Okay, they can be a solution in situations where things are difficult and we have the occasional patient with one, but we try to avoid it if it's all possible. There are surgical solutions to patients with incontinence. So the first thing is to bulk. In other words, put an injection of toothpaste underneath the lining of the urethra to close it off. Now, it's not recommended by NICE guidelines, but I've done hundreds of these operations, and I will get some successful results. It's a simple, minimally invasive, can go out the same day, and it works immediately if it's going to work. And I have had some very successful patients. It doesn't work in everybody, and it's very operator dependent. You have to be good at doing it, and it's a technically quite challenging thing to do, but it's a cystoscopic procedure. What has come on the market recently in the last few years is a male sling. This was based upon what we were doing to women, putting in slings into women. In men it makes no sense. It's a sort of illogical operation, and yet it will work in men with mild to modest incontinence. So through a perineal incision, down here, we will pass needles through your groins and put this mesh under the urethra and pull it up. Okay? We tighten up your urethra, pull it back up, and it works in a number of patients. So looking at male sling results, 51% were dry, and 25% were 50% better than before. But again, look at the follow-up, 52 months, not very long. So these operations are being performed, and we're doing a trial at UCLH of slings versus sphincters to see if they're beneficial, but it's like oranges and apples, or apples and pears, you can't compare them. It's a different type of operation. But in men who've got mild to modest incontinence, a sling may be beneficial. The gold standard is the artificial urinary sphincter, which is the AMS 800, which is the one on the right-hand side. It's a cuff around the urethra, a balloon in the tummy, and a pump in the scrotum. So there's only 297 sphincters implanted in the UK each year. And at UCLH and in our area, we put about half of them in. So we've got lots and lots of experience doing them. People have tried to make a sphincter to replace this, like the one on your right-hand side called Zephyr. They are not as good, they do not work, and this is the best one. It's been available since the early 80s. Very few things have lasted 30 years with such success. It's a brilliant piece of kit. So I put a lot of these in, and when they're implanted through an incision in the perineum or one of the groin, you leave them open for 6 weeks, and then you activate it, and the men are maximally happy. About 80% of men will be dry. Completely dry. Fantastic. There is a complication rate, infection, erosion, and that sort of thing, and they will fail in time. So if you're a 60-year-old and you have a sphincter put in, you're probably going to have another operation in 10 years, or within 10 years. But nevertheless, it can be taken out and a new one put in, and we can fine-tune as time goes by. So incontinence has got multiple causes, it's very prevalent and bothersome, it maximally affects quality of life, but the most important thing is diagnose it, investigate it, give the physiotherapy, and hopefully that most patients will get better, but male slings and sphincters are the best thing to resolve the problem. Occasionally we will divert a patient, but that's very, very rare. To finalise this lecture, in the last few minutes. Obviously, we need to know about sexual dysfunction. You are very interested in that. But sexual dysfunction is a multi-component problem after radical prostatectomy. And the first thing, of course, you can't get an erection. The second thing is you can't ejaculate because there's no fluid left. We've taken out your vesicles and your prostate. You've lost your libido because your hormones may be down, or you're on hormonal therapy, or you're just distressed by the whole process, and there's reduced orgasmic pleasure compared with before. But you still want to have sex, don't you? So we've got to do something about it. There are many causes of sexual dysfunction as we age. And the one thing you have to realise, if you go into a radical P and you haven't had an erection for 2 years, you're not going to get one afterwards. Well, not spontaneously, you will need help. So it's very important when we're discussing with patients before surgical intervention or radiotherapy or hormonal therapy, we discuss their sex. Let's talk about it openly. It's an everyday thing for every human being, or it should be. Pills are amazing. Anybody taking these drugs? Aren't they fantastic?
Brilliant.
Absolutely the most amazing thing. I think Viagra was probably one of the best drugs ever invented. If you bite off a quarter and chew it, it'll give you a really good erection normally, but unless you've had a radical P, of course. But the most prostatectomy is treating early, or even treating before surgery. Get the patient going, get the blood supply going. This is what these drugs do. Cialis lasts for 19 hours, Viagra for 7 hours, Levitra for 7 hours. They take about an hour to work. If you chew them, they take 15 minutes. The one thing that always perplexes me about patients, you know, isn't it funny? Let's be honest about this. How many of you get home and say to your wife, bend over? All right? I don't think many of you. You mostly have to make an appointment. and you don't have to give her a week's notice. So, taking a pill 15 minutes beforehand or an hour beforehand is not a big deal, is it? When people say this to me, I'm thinking, you know, where do you live? You must be in a strange world. So the main thing is, keep the pill in your pocket, and then if you get lucky, chew it. Chew it, it tastes disgusting. And if you're going to kiss her, make sure you've drunk some oranges beforehand. Well, she says, that's a very strange taste in your mouth. The one thing that's very, very useful is a vacuum aid. Anybody got one? Yeah, get them. They're only 150 quid. You put them on your willy and you pump them up and it brings the blood into the penis. So, you know, you notice that after you've had an operation for radical prostatectomy, or as you get older, not all of us, but some people, patients, they say, my willy's shrunk. Yes. Well, the answer is, when your willy's not erected, who's got an erection at the moment? When your willy is not erected, it's only got 30% oxygenation. 30%. The poor bloody thing is scheming. Okay? So you've got to get erections to get the blood into your willy to make it stick out like it used to do like this. So using a vacuum aid is a good idea. Pump it up, get the blood in, and it will help to rehabilitate it. So if you were to vacuum aid your willy every day, it will help the situation. And you can buy a vacuum aid, they're not expensive.
What stage post?
Straight away? Well, no, once the catheter's out. Okay? So if you use the vacuum aid along with pills and injections, it makes a difference to the treatment, okay? It helps the treatment. If you can't get an erection with a vacuum aid or with pills, you can have injections. Who uses injections? Anyway, nobody involved. There must be somebody. So, Cabojex is a great drug. You put it into the willy and you get an erection. So it'll give you a hard erection and it'll last for an hour or two. And so if you can't get an erection with pills, Cabojex. And finally, if nothing works, we'll put an implant in for you. I put an implant into 86-year-olds, and it works very well. There's two types of implants, a bendy one, which is a bit like Action Man, but the trouble is walking around with a stiffy all the time, just a bit of a problem. So baggy trousers, gentlemen. Well, are you pleased to see me? Well, you have an inflatable, which will pump up. The other thing is, if you've got a penile prosthesis and an artificial sphincter, just be careful which one you put. You want to get an erection, not be pissed. So, the trouble with having these operations is it can affect the sensation of orgasm, and that is a problem. So obviously we want to make sure that, you know, patients are reassured about these things, and the more you can, you know, let's face it, you're laughing at these things, so it is quite amusing, isn't it?
Visually as well.
And so if you can talk about this in an open fashion with your doctor, wouldn't that make such a difference? You say, look, this is the problem I've got, it's just, let's have a joke about it, but we'll make it better for you. So, sexual dysfunction after radical prostatectomy or radiotherapy or hormonal therapy is a big source of distress, and it's often not talked about. Whenever I see my patients with incontinence, they say, how's your erectile dysfunction? They've never discussed it with anybody. Can you believe that? It's unbelievable. Doesn't that represent a failing in care? In my view, it does. Because we're all thinking about it and we're afraid to talk about it. So the patient doesn't tell you and you don't ask them because you don't want to have to get involved in the question. Ridiculous. But we can help you. And the earlier the treatment starts, the better. Thank you very much.
Well, was that good or was that good? Fantastic, excellent. Thank you very much, Julian, Victoria. Wonderful, amusing, kept us awake, thoughtful, and I think your last comments were really relevant. You know, if we can't have the discussion, if we can't laugh about it, you know, that's the beginning of the end. We've got to talk about these things.
He's had prostate cancer. He doesn't mind me saying that.
No,
and Bobo set up the Friends of Prostate Sufferers in Chorley Wood. And without Bobo, it wouldn't exist.
Oh, thank you.
I happened to, by my misfortune, meet him in the coffee shop and got inveigled into this business.
Right, I'm starting to sing now, right?
Bobo likes to write songs. So he's written this song, and I didn't bring my ukulele or guitar.
Unfortunately not.
So otherwise I'd be playing in G, and I'll pretend I'm playing in G.
Right,
okay. Give me a G, Bobo. So I'm going to just sing the chorus with him.
Oh, that's kind. Thank you very much.
Go on.
Doctor, please don't send me away. Don't give me more pills than say I'm okay. 'Cause I'm up every night, down in the day. Is this a cancer that's eating me away? Like a train that comes into the station. If you're early, you'll catch it in time. But if you leave it too late, it ain't gonna wait. Then you're at the end of the line. So, doctor, doctor, don't delay in giving me a PSA. Yeah, yeah. Doctor, doctor, don't delay. I need that PSA today. There are so many men get prostate cancer. Every year, 10,000 will die. Doctor, doctor, there must be an answer! Oh, there must be something more we can try. Oh, doctor, doctor, don't delay. Need a PSA today. Oh, doctor, doctor, don't delay. I need that PSA today. This is going to take a while.
Thank you. Okay, let's take a 15-minute break. Are we ready?
Yeah.
Our next speaker, Morven Masterton from Prostate Cancer UK, very kindly agreed to share with us some of the thoughts from Prostate Cancer UK perspective to try and round off and wrap up some of the issues we discussed earlier on about the side effects of incontinence and ED. So Morven, over to you. Thank you very much.
Thanks, Roger. I don't really know how to follow what just happened. I was not anticipating that. Normally I try to put a joke in here or there, but I'm not going to do that today. There's enough laughs, so I'm going to stick to the facts. So, as Roger mentioned, my name is Morven. I am Head of Outreach at Prostate Cancer UK. I've been at the charity now for 4 years, and I'm afraid I am not just Plan B today, I am Plan C, because I'm going to be speaking about a couple of major campaigns where we have 2 different project leads at the charity who unfortunately couldn't be here. So I'm not making excuses, I'm just setting things out from the beginning. I will give space for you to ask questions at a couple of different sections of the presentation, and then I'll leave some email addresses with you afterwards so you can actually follow up with the project leads yourself. So why am I speaking to you today if I'm not one of the project leads? Well, I work closely with Anne and Sue because I have oversight of the support group development team at Prostate Cancer UK. So as you will probably be aware, the support group development team is focusing on a number of different areas. Like Tackle, they are working to improve and expand local peer support. They are also developing peer support, and they are doing that in two different ways. One is through group-based peer support, which we will hopefully be making some announcements towards the end of the year, or maybe even before then. And then also the online forum, which some of you have maybe participated in, sits in the support group development team as well. So that's one area of work, and that's why I'm here. And two other bits of our core focus, let's say, is our health information. And again, you've probably used some of the health information, you probably give it out to group members, and it's one of the, I think, best assets of the charity actually. We have about in the region of 65 different publications now, so it covers the full gambit of prostate cancer and benign prostate disease as well. That's printed and online, and I'm going to mention briefly, I'm going to take the opportunity to sneak in a new development that we've got with some information which I think will be relevant to you and your members. And then finally, the third team that I look after is called Men at Risk, which I'm sure will please many of you because it is very much focused on awareness raising. It's very targeted though, so it's specific to those groups of men who are at the highest risk. The focus is particularly on black men at the moment. We launched a campaign earlier this year called Stronger Knowing More. It's meant to feel like a national campaign, but it's very much targeted at London and the South East and the West Midlands, because 75% of the black male population are based in those areas. We're using high-profile celebrities to get involved, and this, as you will be aware, I'm sure, is because black men have a higher risk. 1 in 4, as opposed to 1 in 8, have been diagnosed in their lifetime. And not only that, they have an appallingly low level of awareness about that risk, which we polled it at 14% to about 18 months ago. So we are looking to increase that significantly. This is news for you first, as a partner of ours, I suppose. We're going to be looking at family history as well, because we've done some recent research which has demonstrated that health professionals, particularly GPs, are not being proactive in terms of finding out about family history. So if you keep your eyes peeled on Sunday, you will hopefully find some press coverage about some new stats and information to try and raise awareness about risk associated with family history. So that's me. That's my sort of expert areas, and I'm now going to move on to the subject area that I'm less expert on, but I thought Anne and Sue and I spoke about this, and we think that this is probably most interesting for you at the moment. So I'll start with a bit of the bigger picture of Prostate Cancer UK. You may be aware we introduced a new strategy in early 2016. The strategy is all about taming prostate cancer, and what we mean by that is fewer men dying of prostate cancer, and those who are diagnosed with prostate cancer will have a reduced impact of their treatment and better quality of life post-diagnosis and treatment. There are 4 different elements that the strategy is split into, the 4 that you can see, which I suppose are quite obvious, but huge different aspects of prostate cancer. And the 2 campaigns that I'm going to talk to you about today are associated with the 4th one, which is about better support. And that's obviously very much focused on providing better support to men with prostate cancer now. So, to start, the first campaign. Thanks to Julian, I don't really need to introduce this subject because obviously he's demonstrated why this is such an important issue and what kind of impact it can have on individuals. So we launched a campaign late last year, November time, which is focused on improving treatment and support for men suffering from erectile dysfunction as a result of their prostate cancer treatment. Our aim is to ensure that all prostate cancer patients receive standardised, up-to-date ED care and support, providing individuals with a choice of support services regardless of where they live in the UK. And as you'll have seen from the title of the session, this is very much, the emphasis is on variation of care across the UK, and I've got some data which will demonstrate that in a moment. So, the campaign aims and objectives. They're kind of centred around a few different areas, but I suppose they're all very closely associated. The first part is around the ED national guidance, which we want to have updated. I'm going to talk about that in a little bit more detail a few slides ahead, so I'm not going to go too much into it. But essentially, it's making sure that the guidance supports providing the services and treatment to help men return to their baseline function that would have been measured pre-treatment. We want all men to have access to the following 5 ED services and support. And some of them have been demonstrated in the previous slides. So daily Cialis, vacuum devices, ED clinic, psychosexual services and counselling. And the reason why those 5 services have been grouped together is because we carried out some work with the Royal Marsden a couple of years back. So a couple of experts there, as well as a quite well-known GP who specialises in men's health and prostate disease, and they came together with recommendations about what should be the sort of standard of care and package of care that's provided to men post-prostate cancer treatment. And those are the 5 recommendations we have, so that everything that we are trying to do is kind of framed around making sure these 5 services are available to every man in the UK. We also wanted to ensure that men were empowered to campaign themselves to improve their services locally, and I'll go into a bit more detail, and there's a good chance that you might have participated in that survey work that we've launched already. We're also trying to promote, or at least help health professionals and commissioners recognise and prioritise the need for prostate cancer patients to have support and services around erectile dysfunction and the impact that it has on their lives and the wider health impact around them. And we want to support those health professionals and commissioners to improve the services in their area. So this is not a sort of banging people over the head exercise. This is recognising the challenges of the NHS, recognising the limitations and trying to work with both men and health professionals and commissioners to try and improve where they're at the moment. So, hold on a minute. There we are. So, where we are now. We carried out a survey in 2012, again you may have participated in this, and these are some really interesting statistics that have come out of that. So for those men that were treated with prostate cancer, 76% that they said they experienced erectile dysfunction, only 30% said that their ED treatment met their needs, and 47% said it had an impact on their relationships. We followed that up 2 years later, or about 18 months later, and we've got similar statistics, which I don't have to say that there's not enough capacity of clinical nurse specialists, and actually if you can improve the time and the number of clinical nurse specialists you have, you might tap into some of these problems as well.
I would agree with you.
Okay, thank you. Should never have opened it up to the floor. I'll learn that for this one. Right, so I've got maybe 5 minutes, if that's okay. So this is quite brief. The focus is very much on improving access to clinical nurse specialists. Our call to action, or at least what we want to achieve, is that every man living with and beyond prostate cancer has access to an expert specialist nurse who can effectively support them at specific points in their pathway, in their treatment pathway. We're doing that because we know that men report better experience of care when they have access to CNS, and that's connected to work that Macmillan's done, and also the National Cancer Patient Experience Surveys as well. These are some of the advantages of having access to clinical nurse specialists. It's about the emotional support, it's about providing information and advice. It's also the point I made about having expert care in terms of ED and continence issues and fatigue and all of those other things that often are the kind of the unspoken effects of prostate cancer.
Can I just interject, and I am going to be that irritant. My sadness is that prostate cancer is not acknowledging the role that physiotherapy have brought to this area and the education we've given to clinical nurse specialists. And that's not me just having a but really what it should be saying is access to a team.
Or you could say access to a key worker as well. So some radiographers would say where they have site specialist radiographers, they will come in and play that role too. So yes, I hear you. It's probably wider than this.
Yeah.
But the focus of this, to begin with, is clinical nurse specialists.
It's changing all the service provision that's being the commissions are prepared to take on board, and they are giving some of these roles to people who have not even had full trainings, and they're not clinical service specialists. They're taking it right down. Yeah.
Okay.
Sorry,
no, that's fine. So, a couple of years back, in 2014, we commissioned some research into clinical nurse specialists in urology, with this, and obviously with a specific focus on prostate. What it found is that caseloads are huge, and by far the biggest if you look at clinical nurse specialists working across different cancer sites. Compare it with breast, for example, and we're told that we shouldn't really compare it because the needs of patients are different, but it is a significant difference in terms of the number of cases that a urology nurse will have to manage as opposed to a breast cancer specialist. There is a major issue in the pipeline in terms of strategic workforce planning, and what I mean by that is there were research demonstrated that almost half of clinical nurse specialists were planning, in urology, were planning to leave or retire, either leave the NHS or retire in the next 10 years.
Or be pushed out.
Or be pushed out because there isn't. The point is there's a potential crisis in terms of expert specialist support in urology and in prostate. Education is often something that nurses are having to do in their own time, or it has to be supported by pharmaceutical companies or charities. They also reported that multidisciplinary teams weren't working effectively, and often nurses didn't feel that they had the confidence to speak up in multidisciplinary teams, and when they are the key worker, often the voice of the patient, that means that man's voice isn't being heard in that discussion group. And huge variation across the UK in terms of this access to clinical nurse specialists. So this is where this piece of work has come from, this research. We know that there is a sort of forthcoming crisis, and at the moment, men don't have enough access to clinical nurse specialists.
Can I just mention, you've given bad news, but I'm going to give good news. Your charity, Prostate Cancer Charity, helped us with funding for 2 nurses originally, which you've stopped funding now because you funded 47 and you changed direction. And they were the 47 nurses you've got. But we've now got 3 nurses, which 2 of them are jointly funded with the NHS. We work with them, and the prostate specialist nurses based in Leicester, the biggest amount of prostate cancer nurse specialists with a monitoring assistant as well, anywhere in the UK. So it isn't all bad news, please. We're working hard, we're a charity, prostate, and that's what we do. Okay.
Absolutely, but that highlights the variation in that there are some places that have that and others that don't.
What I'm saying, you've got to work at it. We've been at it for 10 years. We work with the National Health. They're great. We've got a wonderful relationship. We've got dedicated professionals, and you help us train them. Okay. So it's not all bad.
Thank you. So what we're doing in this area, there's sort of 3 different strands to this approach, and this is for the next 6 months. So we are working with governments, the NHS, NHS bodies, cancer alliances and other key stakeholders across 4 nations, calling for decision makers to address gaps in urology. The way we're doing that is 3 out of the 4 nations have new cancer strategies. Some of the emphasis is on workforce, and we will be ensuring, or we will be working to ensure that prostate and urology is a focus of that. We are also working with MPs and encouraging them to ask parliamentary questions on the issue in order to raise the profile of it. And we are part of a group called the Common Cancers Coalition that acts as a sort of campaigning body where together we can have more influence, and they have a subgroup that's specifically looking at workforce issues as well. So that's the first thing. The other element is that we're actually trying to inspire the existing nursing workforce to specialise in prostate cancer and urology. We're doing that through working with the Royal College of Nursing, attending conferences, speaking about the benefits of working in this area, sharing more information about what this specialism entails. We provide free education. As I explained with ED, we also provide free education covering lots of different aspects of prostate cancer, and we provide bursaries, and bursaries can fund things like nurses who want to do a master's in prostate cancer as well. So we are trying to kind of feed the system at the moment by encouraging people to move into this area. And then thirdly, we are working with Bown and other experts, researchers and academics, to look at developing a urology career pathway to demonstrate what a pathway might look like for a nurse who wants to go into urology or prostate cancer specifically. We've just started these activities. We'll be running them until October of this year. We'll then be reviewing and evaluating what kind of difference we've made. This is a very small amount of time, so we'll be kind of just trying to see if there's any ripple effects, how much impact we're making in terms of the cancer strategy, how many nurses are taking up education with us, and so on. And these will be indicators that determine whether we continue to work in this area. And I think, yeah, that's it. What I've got here, my own personal email address, but also the two contacts that are the project leads for the different campaigns. So we've got Stephen Roundtree, who's based in the North East. You can contact him about the erectile dysfunction campaign, and to do with the CNS and possibly wider workforce campaign. That's Jane Fairfax, she's based in London, and you can be contacted there. Do I have time for questions, or?
Yes.
Any questions?
With whom are you offering the masters for your retraining of?
Sheffield Hallam, and they do quite a flexible, sort of open learning course, which makes it more accessible to people across the UK.
How long does the masters take on that course?
I'm not sure entirely. It depends on who the nurse, who the person is that's studying it to a certain extent, but it's probably anything between 12 months and 3 years.
Would it be on the job, or would it be a taught course?
It's on the job, but with taught elements to it.
Thank you.
4:30, but we do have Prof Nick James here, so thank you very much indeed for coming along. I know it's a very extremely busy time for you. So let's hear about Stampede and post-Stampede. Thank you.
Thank you. My apologies for the for my late arrival. My wife had an operation yesterday, and it was a hectic couple of days, I'm afraid. So we're going to fetch her from the ROH when we're done. So what I'm going to do, I've got a mixture of 3 talks. So I'll start with the talk that we did for the press briefing from the trial, because that's in kind of lay terms, if you like, and then I'll switch to the presentation of the data that we gave at ASCO, American Society of Clinical Oncology in Chicago last week, which some of you may have seen got a fair bit of press coverage, rightly, I have to say. So we're at the opposite end of the spectrum from the discussion you've just been having around who you should diagnose, and I have to say it's a really complicated subject. Who should have PSA tests and who shouldn't, and it's not that people like myself are ignoring the issue. There is a really big issue of overdiagnosis and over-treatment of people with trivial disease that helps nobody, frankly. So I don't know what the right answer is. I think the right answer is better tests, not more testing with tests that we know don't actually work very well. But that's probably, I know it's a controversial topic and a separate discussion. So we're interested in men who are diagnosed with disease that might kill them, basically. And so we chose to define that as people who are starting long-term hormone therapy for advanced prostate cancer for the first time. As I suspect everybody in the room knows, hormone therapy, androgen deprivation therapy, whatever you want to call it, has been the mainstay of treatment since the 1940s. There have been remarkably few changes to that in terms of the primary treatment, as opposed to treatment of relapse, where obviously we've had a lot of new drugs diagnosed over the last few years, and actually we've been involved in the trials of all of them at Queen Elizabeth. So we've been very pleased and happy with the progress that's been made in treating relapsed prostate cancer. The question is whether you could do better by using some of these drugs earlier. So basically, we know that abiraterone prolongs survival if you give it to men with relapsed disease. So the hypothesis from the data we presented last week is that instead of waiting for people to relapse, we should be better off showing treating men at the time of diagnosis and starting their long-term hormone therapy. And as, again, I suspect a lot of people in the room know, but I will just briefly go over it. In Stampede, we've used it as a platform for testing multiple different treatments. So it's a multi-arm trial, so it's not the usual A versus B trial with a control arm and experimental arm. The problem with designs like that is that only 1 in 3 trials, randomized phase 3 trials, comes up in favour of the new treatment. So 2 times out of 3, you put 1,000 people into a trial, follow them up for 5 years, and then concluding that what you were doing in the first place was fine. So essentially, this was an effort to hedge our bets. If we put in more experimental arms, it's like running lots of trials at once. You've got more chances that one of the experimental treatments comes up positive. It also means, from the patient point of view, instead of a 50-50 chance that you get the new treatments, as we started at the beginning with 5 experimental arms, you've got 5 chances out of 6 of getting a new treatment, which at the start we were concerned would be confusing and actually put both patients and clinicians off recruiting to the trial. But we now know, with the benefit of 10 years or more of running the trial, that it's actually perceived as being a positive thing in the main. People go into trials because they want to get a new treatment, not just because they want to get the standard treatment which they could have had without being in the trial. So from that point of view, it's been successful. Obviously, trials cost money. So if we run a trial with 5 experimental arms instead of 5 trials which would therefore have 5 experimental arms, we've actually saved a lot of time and money because we haven't had to recruit out 4 extra control arms getting the standard treatment. We just have 1 control arm getting the standard treatment. So it gives you quicker, because you need fewer patients, and more economical answers, and there's obviously only ever a finite amount of money for anything, to ask multiple questions. And it turns out from the 6 arms that we've reported survival data from so far, 3 of them have shown a survival advantage. So roughly half the patients who've gone in the trial have got a treatment that has given them a longer survival than the control arm. So it kind of indicates the design, really. We also separately do multiple analyses as we go along, and so this is a bit like a high jump contest. In order to stay in the trial, any given treatment arm has to be outperforming the control arm by preset measures which we analyse as we go along. And as I said, this is the 6th set of survival results we've now supported from the trial. We've got 10 arms either going or gone or in set up now. And so far we've recruited more than 9,000 men to the trial, which is pretty spectacular. And almost all of these are recruited in the UK. So it is actually a testimony to the NHS and the UK academic system that it is set up to recruit so many people to a clinical trial. The UK puts more people into clinical trials of cancer than any other country on the planet, bar none. Not correct of the population, just bar none. We are very good at clinical trials in the UK. In this particular bit of the trial, if you were eligible for it, you had a 50-50 chance of giving us the abiraterone arm. There were other arms recruiting at various times. So the thing, but in terms of the analysis I'm presenting to you, it's the patients who went in the abiraterone arm and the patients who in parallel went into the control arm. There were patients going into other arms along the way. We were targeting 25% improvement in survival times, which is we felt was clinically realistic and clinically significant. We did 3 interim analyses in 3 cleaning bits of the high jump contest, and the arm got through all of those. And so what I'm presenting is the primary outcome measure, which is survival. So in terms of the patients who went into the trial, the median age, that's to say the value in the middle, if you line up all the ages from the youngest to the oldest, was 67, with a huge range from 39 up to 85. 78% of the men going in were able to carry out completely normal daily activities, and all bar 1% of the remainder were functioning pretty well. So we didn't have heavily symptomatic patients and large numbers going into the trial, which is important. Around half of the men going in had disease that had already spread at the time of diagnosis, mostly spread to bones, but you see 12% didn't have bony spread. of the remaining 48%, they split almost 50-50 between high-risk disease confined to the prostate only and disease that has spread to pelvic lymph nodes, and almost all of the patients, 95%, were newly diagnosed. A small number, 5%, had either previous surgery or radiotherapy and then relapsed without having a lot of hormone therapy. So what I'm going to do now, apologies for switching between presentations, is I'm going to switch to the actual hard data. So the data I just showed you was from the ASCO press conference, so it was featured as one of the highlights of the meeting. It's a big meeting, it's about 30,000 doctors and so on go to it. So to be featured as one of the highlights tells you how important the cancer community at large thought these data were. So, what we previously showed in the Stampede trial, as those of you who were here 2 years ago will know, was that some of the earlier arms we analysed contained the drug docetaxel chemotherapy drug. And what we showed, this is the Lancet paper that came out the back of it, was that docetaxel, given at the time of diagnosis, improved survival by 25% compared to saving it for relapse. And that, of course, was a big result as well. A couple of papers published. And we were very happy that NICE and NHS England and the parallel Celtic NHS versions all changed their commissioning guidance in year, which is actually very unusual. Mostly the NHS takes a while to decide that it wants to change practice because they've already allocated the budgets for a given year. So to actually get practice changed in year shows you that, again, the results were highly impactful. I have to say, one of the reasons it got changed in year was because I had to have presented the data at this meeting 2 years ago. And what happened was that NHS England actually said at the time that they were not prepared to change on the basis of the data that I just presented the week before. And so trusts varied in what they did with the data. So the QE where I worked, so I just went and showed them the data to the trust exec, and they said, that's fine, it's the right thing, give patients the treatment. All of the surrounding trusts, Wolverhampton, Coventry, Stoke, Shrewsbury, all said, you're not allowed to do this, it's not commissioned. And what happened after I presented the data here is I very predictably got patients who'd been told that they couldn't have the treatment, asking to see me for a second opinion, and the first one that came along, I said, do you mind if we publicise this? Again, my trust backed me and said, it is still the right thing to do, even though NHS England now told us not to do it. But they said, rather amusingly, the NHS data systems are such that although they know we're doing it, they don't know which patients we're doing it to. So basically we did it, got a lot of press publicity off the back of it, questions in Parliament and all the rest of it. And when I then recontacted NHS England, they said, can you come and see us next week? At which point Jeremy Hunt had already told them they had to sort it out. So they did, their policy is they won't change policy on peer review until something's appeared on paper in a journal as opposed to being presented at a conference. So you can't see the date on this, but the date of the article on the left is the same as the date as the NICE guidance on the right. They published it the same day, they lined it up in advance. So you can indeed change things by pressure through the press is the message from this. And so the data I'm going to show you now is from the patients recruited in yellow here between 2011 and 2014. You'll see that this overlaps with the tail end of the docetaxel data. So we didn't know at the point when we were recruiting whether docetaxel did or did not improve survival. So none of the patients that I'm talking about today had docetaxel as part of their standard care. So docetaxel, sorry, our question at the front is lines C and D. We had 2 docetaxel containing arms. You'll also see that there's 2 arms, D and F, that stopped earlier, and that's because they didn't get through all the interim analyses and stopped. Although as it turned out, one of them did show a survival advantage in the end. So I'm not going to walk you through the biochemistry of this, but basically what abiraterone does is it stops prostate cancer cells making their own supply of male hormones, which turns out to be one of the ways that standard hormone therapy fails is that you've got this, if you like, testosterone dragged in the bloodstream, but the cancer cells have the ability, they have the enzymes required to synthesize things like testosterone, and what happens in cancers that are relapsing is that process gets increased in activity, and abiraterone blocks that from happening. It gives you a sort of more complete androgen depletion, if you like. That is the biochemistry of it, but I don't think that particularly need to go into that in detail. As I said, the inclusion criteria were men with advanced disease starting hormone therapy, so that is either men with disease that's spread already, that spread to the lymph glands in the pelvis, or that just has bad risk features, so high Gleason, high PSA, but no spread. So the patients who fell into the last category, no spread but bad features, all got radiotherapy as well, because we know that that improves survival. We did have some patients, I won't go through the details of that, but basically patients who had prior surgery or radiotherapy, but no hormone therapy is essentially what that says in a nutshell. And very simple further conclusion criteria, patients just have to be fit for the relevant treatments and given written informed consent. The Stampede Trial website includes everything I'm showing you now. It includes various patient videos and things which we produced to explain the results. So, and also for those taxol data, we produce videos of the results as well, in lay terms. And the primary outcome measure is survival. But we also showing data on failure-free survival, how long patients take to relapse, side effects, because obviously they're important, and lethal-related events, because they're important as well. We haven't analysed the quality of life and cost-effectiveness data. Let's go through that. I've shown you this already, that's the stats plan. So, at this point, at the point we stopped recruitment, we had 1,900 men recruited into the trial, split evenly between standard treatment and standard treatment plus abiraterone. And again, I've shown you that already, sort of in English as opposed to in stats speak. So, this is the important stuff. So if you look at the top right-hand corner, what is rather euphemistically referred to as events is unfortunately deaths. Now you can see on the control arm, at the point where we had the data, we had 260 deaths on the control arm versus 184 deaths on abiraterone as well. And that's clearly a huge difference. Now, obviously, we have to test whether that arises by chance or not. And so these are, I'll show you a whole series of these. I just forgot a pointer. There we go. So just to explain what you'll see a whole load of these curves. So basically, this is, in this case, the percentage who remain alive, or the proportion who remain alive. So obviously, 100% are alive at the beginning. So at this point, for example, 60% are still alive, 40% and so on, versus time. So if we pick this point here, you can see that at 54 months, we've got about 60%, 0.6, of the patients on the control arm still alive, versus a rather high percentage on the abiraterone arm. So there's quite a significant gap between these two curves. So this is a common way of showing survival data from clinical trials. Now, again, I'm not going to trouble you with too much statistics, but you'll see these figures on all of the graphs as well. So HR stands for hazard ratio. Now this is the ratio between what happened in the control arm and what happened on the experimental arm. So if you've got a hazard ratio less than 1, it means your probability of being alive is improved. So in this case, it's quite a lot less than 1. This is a 37% improvement in your chances of being alive at any given point after the trial opens. That's bear in mind we're trying the 25% gain, which we already thought would be pretty good. That's a pretty good result. The other thing you'll see on here is the p-value. So this is the probability that the result is a fluke. So you'll see that there's a lot of zeros in here. So this is something of the order of 1 in a million chance that it's a fluke. So it's probably not a fluke. I'm not going to show you all of this, but this is just a more detailed breakdown. The second thing that we looked at was what was the impact on time to relapse. And at this point we have 535 patients on the control arm who'd relapsed, out of around 900. So again, if we look at the ratio of the two, you can see that out of 900 patients roughly in each category, you've got 535 who've relapsed on the control arm, which is in line with what we expected, and it's very similar to what we saw with the previous docetaxel data, not very surprising because they've been treated the same way, versus only 248, so under half have relapsed at the same time point on abiraterone. So clearly that is a huge impact. So back to these curves, you can see that if we look at any given time point, we look at around 3 years, you can see that only about 40% of the patients haven't relapsed, versus 70% of the patients haven't relapsed at 3 years on the abiraterone. But bear in mind, of course, you'll notice these curves are further apart than the other ones, because of course you've used up one of your salvage treatments as a result of shifting it to the front. So you do get catch-up after relapse because you haven't got so many treatments left. But even so, that is a huge gap. So again, back to these figures. For those of you who are mathematically literate, there are 61 zeros. So I don't know how you describe that in words, but it's a very big number. It's a very small number, I suppose. Yeah. So it's a highly significant result, and a 71% improvement in the failure rate, which is colossal by any standard. And I honestly can say I haven't seen differences this big in any clinical trial in an adult cancer. There are huge differences. And there's, so what's, again, I'm not going to walk you through the stats of this, but basically we looked at various subcategories, whether the disease had spread or not at the time of diagnosis, age, under or over 70, whether or not patients got radiotherapy, various things. The effect's the same. Whichever subgroup you look at, you see the same effect. So there's no suggestion that there's any subgroup that does better or worse than any of the others, which is what all that stuff means. So the other thing that we were very interested in was skeletal-related events. So this is pathological fracture, surgery to bone to prevent a pathological fracture, spinal cord compression, which leads to things like paralysis, or radiotherapy for bone pain. Now all of these things are things you want to avoid, and they're all very unpleasant and clearly highly desirable to avoid. Now I'll focus on the patients with metastatic disease, because these are patients who all pretty much had bone disease to start with, and what you can see is that again we've got a huge amount of daylight between these curves. So we've got a hazard ratio of 0.45, so that's a 55% reduction in skeletal events, so over halving of the number of nasty things that happen after they relapse. So you don't start getting skeletal events until you've relapsed. So the interesting thing about this is that you delay the time to relapse, but once you relapsed, things happened at half the rate. So it looks as if you changed the biology of the disease after relapse as well as before, which is in itself very interesting. And clearly highly clinically and statistically important. We looked at what treatments people got next. I'm not going to trouble you with too much of this, but the main point is that the patients who had abiraterone first mostly got docetaxel as their next treatment, whereas the patients who didn't get abiraterone first mostly did get either abiraterone or enzalutamide, which, as many of you know, is a similar drug as their relapse treatment. So the differences in survival are not driven by differences in access to treatments later on, which we know were good. If we focus on side effects, outlined in red, so serious side effects, we grade them on a scale from 0 to 5, increased. So there is a price to pay, apart from the monetary price, in terms of side effects. And if you look where that excess sits, it sits where we know the side effects of abiraterone are already. So we didn't see unexpected side effects. So you can see that this was mainly driven by increased blood pressure, which we know is a side effect of abiraterone, went up quite considerably, more than doubled, and changes in liver enzymes, which again we know is a side effect of abiraterone, actually quite easy to manage, went up from 1% to 7%. So although there's an increase in side effects, these are actually most of the side effects that don't bother people too much. So I'm guessing some of you in this room will have been on or are on abiraterone. It's generally pretty well tolerated. That was what our finding. And I'm not going to show you this. Because I'm assuming there's going to be, if we finish, I'll pass questions. So the conclusions were that survival improved by 37%, failure-free survival, time for relapse by 71%, symptomatic skeletal problems reduced by 55%, broadly the treatment was well tolerated, so our conclusion was this should be part of the standard of care. So the final slides I just showed in America, so the paper was published simultaneously, bearing in mind the problem with docetaxel, we got this into the New England Journal of Medicine, and it was published simultaneously with my presentation the weekend before last. And we had this amazing cast of thousands of patients in the trial, more than 3,000 people altogether, which is pretty amazing, and huge team managing all the data, and finally 9,000 men have taken part in the trial so far. Okay, thank you.
Thank you very much. Any questions, Phil?
Please may I be reminded of the start date of the two principal graphs you show. One was over 50 odd months and one over 36 months.
So you tell them to stop.
Yeah, that was over 30. That first one, the earlier one was over 50.
So,
and that was the first one.
Yeah,
that's the start date line.
So basically the point where it starts is these are durations along the bottom, so it's not a date, it's for each patient in the trial they start at 0 and we collect data periodically. And
well, that line on the left is when you dealt with the first patient.
No, it's the 0 months follow-up for each patient in the trial. So this isn't so basically for each patient in the trial we have data out to however many years we have, and we can the stats of this is quite complicated, but there's not a date on this, it's a duration from when they went into the trial to when, in this case, when they died, basically.
May I ask again, was abiraterone given throughout the whole period of that graph?
So that's a very good question, and the answer is, for the metastatic patients in the trial, it was given until they stopped benefiting from it. For the non-metastatic patients, it was given for a period of 2 years and then it was stopped. In fact, they stopped all their treatment in 2 years. So we've got a more detailed breakdown by the two groups, but basically the magnitude of the effects is similar. I mean, it turns out that happily very few men with non-metastatic disease have died. So, for example, only 35 have died on abiraterone out of the 450 or so who were non-metastatic. So we'll never probably be able to make very firm conclusions about the impact on survival if it turns out to be so good. But the effects were very consistent in their magnitude, essentially.
Thank you.
Thank you.
Does this mean to say that you've got to persuade NHS England to change their guidelines again?
Yes, so we've already started discussion with NHS England, but this time at least we're in a slightly happier position because I haven't shown you the data, but we've got a further round of data that we're presenting in the European equivalent conference in September. So basically, this arm overlaps with the tail end of the docetaxel arm. So we have basically around 600 men who've either had abiraterone or docetaxel. So we can essentially look to see which ones did better. Now, it's not a fully powered up comparison, but broadly speaking, the magnitude of effect turns out to be quite similar on survival to the effect of upfront docetaxel, which is available. So what I'm having to say in clinic at the moment, and I suspect I will be saying for a while, is that, sorry, this isn't available for newly diagnosed patients, but we can give you a treatment that has similar benefits already, albeit with, accept different toxicity. Now, as to the cost effectiveness, we are doing that analysis, and there was a second trial presented at ASCO, which was a commercial trial which had almost identical results. So it's already in the NICE system. It was already in the NICE system before we presented the data, because everybody kind of assumed that it would be a positive trial. It's likely to be 6 months before the abiraterone license is changed to permit use of diagnosis. Because it's more expensive than docetaxel, I think it's going to be harder to sneak under the radar in the way that we were able to sneak docetaxel under the radar. Not least because of the, I'd have to actually perjure myself on the application forms, which I'm not very comfortable doing. So, you see, if they don't ask, I'm not lying, but if they do ask, I can't lie. That's the problem. And because it's an expensive drug, it's released.
Was the trial you referred to, was that the Latitude trial?
Correct.
It seemed to come out with
it came out with identical results. It was only metastatic patients, so not non-metastatic.
Yeah. So the things that, because they were referring to the United States and it also means, unfortunately, that most insurance companies do not realise this is going to be the new standard of care. Yeah. They may not want to pay for abiraterone, and that's a problem, because the drugs out here, Maybank Chancellor, is not cheap. It costs £9,000 a month.
Yeah, the interesting thing about that is that we don't know what the NHS pays because it's confidential and it's kind of redacted from all the documents, but it's probably somewhere between £1,000 and £2,000 a month, which is still a lot of money. But, I mean, one thing that illustrates is the sheer idiocy of the way the Americans organise their healthcare system, because it's the home of free trade, but they don't have a free market in drugs. Because you think if we're paying that and we're paying much less, you just buy your drug here and ship it there. That's not allowed. The list price in Europe is €5,000. So it's a weird thing. But yeah, no, the same issues arise in all healthcare systems, that there is not a limitless pot of money. And it is expensive, it's true. Yeah.
As far as Stampede is concerned, where do you go from here, please?
So, you'll notice that on this graph, which has got all the various arms that we've done with the time that they've been recruiting, that we've got 4 further things on the graph there, and you can see that some of those have already finished, so we will be reporting results for men with metastatic disease who've been randomised to standard treatment, which by this time included docetaxel, versus standard treatment plus irradiating the prostate to a radical dose. So we'll have the data on that next year. We did a second arm that we adding abiraterone and enzalutamide together, because although they're similar drugs, they actually, each one targets the mechanism of resistance to the other. So you predict you might get better effects from combining them. Maybe don't go very well if you use one after the other. We're just about to open, we've just opened recruitment to testing metformin, which is a diabetes drug which we think might be disease modifying, because cancers handle sugar in a different way to non-cancer cells. And there's a lot of data suggesting that metformin interferes with the way that cancer cells handle sugar from looking at diabetics. Now, we are testing it in non-diabetics to see if that is a real effect or some sort of fluke. So we will know the answer to that, not for a few years. And then, so as again, as some of you may also be aware, there's a trial running in the UK called PATCH, which is testing estrogen patches as an alternative way to suppressing testosterone. Now, when the Stampede and PATCH trials were set up, we were testing chemotherapy, and PATCH kind of recruited men who weren't fit for chemo. But now we're testing treatments that you can give to anybody, basically. The PATCH trial is struggling to recruit, and it's actually producing some very interesting data about equivalence of effects on testosterone, but beneficial effects on things like bone density, cholesterol, blood sugars. So what we've chosen to do is add a PATCH arm to the trial and then analyse the 2 trials together. So that's about to open within the next few weeks. And then the next thing that we're going to open, which is in setup, is, again, some of you may have seen that data published last year by the Marsden looking at drugs called PARP inhibitors in men with DNA repair deficits. So we're getting to quite small print stuff now. But basically around about 30% of relapsed prostate cancer carry BRCA2, for example, which is, if you like, the Angelina Jolie gene. So this is a gene that's commonly abnormal in breast and ovarian cancer. It turns out to be a factor in some prostate cancers. And we think that it's about 10%, give or take, depends how you define the abnormalities, in our newly diagnosed metastatic patients. So in order to, it only works if you have a relevant mutation in the tumour. So we are setting up testing of newly diagnosed men as we speak, and have funding to do that. We have funding to add the drug to a PARP inhibitor to the trial, but only for the men with the relevant abnormalities. So that is quite a challenging thing to introduce, because we have to get the samples out of the lab to a centralised lab, have them sequenced, have the data back in time in the 12-week window that we recruit to. Which turns out to be not a trivial exercise. It's a logistics exercise. The science is sorted, but the practicalities of getting things out of NHS labs in a timely fashion are not trivial. But we're very excited about that, because that's kind of the future, really, is slicing it down into different subgroups. It's what's happened with breast cancer, and we're starting to be able to do it.
Thank you.
Thank you, Jim. I think we should maybe draw it to a close there. I think we've taken enough of Nick's time, and I know enough of your time. I promised we would finish about it. So thank you very much for the time and effort again, Nick. It's most wonderful. So don't forget to fill in your assessment forms. Don't forget to fill in your expense forms. Have a safe journey home. See you next time. Thank you.